you everyone for being on today. I'd like to briefly introduce everyone on the panel. I'm Phoenix Nguyen. We have Dr. Sonia Riker from Harbor UCLA as our moderator today, along with me. Dr. Kenneth Cheng, who doesn't need an introduction, but he's the Chief of Gastroenterology at UCI Medical Center. We are very honored to have Dr. Juhao Wang from Stanford. Welcome, everyone. We are, as a follow-up or a Q&A to our lectures on the AWE week. The Q&A session will start off with a few cases and discussion of the cases. They're not meant to be a in-depth discussion, but just to discuss, to start off the discussion with the cases. So if we'll have everyone say hi.
Hello.
Welcome.
Everybody.
We'll start off with this wonderful case here from my institution. This is a 48-year-old. She had an endoscopic ultrasound for a high-risk indication, and she had a gastric sleeve about 8 years ago and had weight regained, and now is very symptomatic with reflux. And she has, as noted on the left, esophagitis and a fairly patulous G-junction with a sizable hiatal hernia that was noted on EUS. The bottom of the screen, you'll see some surgical changes at the greater curve. Retroflex view distal to the narrowing in the body of the stomach. So this is seen from the distal gastric body. So approach to management of this case, we'll start off with Dr. Cheng.
Yeah, so very interesting case and something that we see not infrequently. So the first, and we need to consider the patient obviously as an individual, and she's got obviously refractory GERD. I'm assuming she's on PPI and breaking through. The other issue then is her weight. I know she's regained weight, but what is her current BMI? Because that'll factor into the options for her.
Currently 38.
38? Okay. So BMI 38. So she needs help with her weight control, obviously, as well as her reflux. Any other metabolic issues, diabetes?
She's well otherwise, just the regurgitation and heartburn.
Okay, and liver's okay?
Yes.
Okay. Yeah, so with a GERD and a BMI of 38 after sleeve, the options are first consider conversion to a gastric bypass with a hernia repair. That would be the most aggressive, the most maybe definitive, but one could argue that the amount of weight loss would be a little bit too much, and the patient may or may not want that kind of anatomic alterations. But I would say that would be the first thing to consider and the most aggressive. Second, in terms of surgical, to revise, to go in, to do any kind of fundoplication would not be possible given the altered anatomy and the sleeve anatomy. There's no fundus to wrap, and just doing a hernia repair would not be sufficient. But you could pair a hernia repair with links, and that would take care of her hernia. It wouldn't address the weight loss. So then you would want to consider, obviously, GLP-1s and other medications. I guess the other is to just put her on a GLP-1 and aggressively manage her medically and see if weight loss can also help her to control her reflux. And obviously, the middle ground, which we want to talk about, are the endoscopic options. So if we think about, say, TIF. So TIF alone would not be an option or a great option. Two things. One is there's a 2 centimeter sliding hernia. And so TIF alone would not be able to address it. And also because of the small, relatively small gastric lumen, it'd be mechanically difficult to retroflex the TIF device in a narrow lumen. So that would be difficult. So yeah, and that would be the same if you did a laparoscopic hernia repair plus TIF. It would be difficult if you don't have the space. Now, if the gastric lumen was wide enough, one could consider a hernia repair plus TIF, the C-TIF, as a possible solution. But looking at the lumen, I don't think it's possible. And then finally, there are the other endoscopic procedures that can create a gastric plication. There's ARMA, there's MAZE, there's TIF. There's RAP. These are all different approaches to create narrowing at the G junction, but mostly working on the gastric side and not on the esophageal side. So you can ablate the gastric mucosa and let it heal and narrow. That's the ARMA. You can do wide endoscopic resection and piecemeal resection in the G junction and let that heal. And that can cause some narrowing. That's the ARMS procedure. You can do ablation combined with suturing. That's the MAZE procedure. Or the one we do the most of at our institution is we do wide resection EMR followed by suturing, and that's called the RAP procedure, resection and plication. So in this patient, you could also do an endoscopic revision of the gastric sleeve for the weight loss. So one potential approach for this patient is to do the RAP procedure plus endoscopic revision of the gastric sleeve. Do them both in the same session. This would be both done non-surgical, and that may be sufficient, maybe not forever, because the RAP may loosen over the next 5 or 10 years, and the weight may come back in 5 or 10 years, but that may be the less invasive approach to get her, through this next 5 to 10 years. So I think I would boil it down to either the more aggressive, which would be a laparoscopic hernia repair plus links for the reflux, versus an endoscopic approach with RAP plus endoscopic revision. But I'd love to hear what Juha would think. What are some options?
Yeah, I mean, you listed all the potential options. I think most of them are fairly experimental and really new, and probably you might be one of the very few people in the world that do most of them. I look at these pictures and I think that her biggest problem is the diameter of her diaphragmatic hiatus. I think that is the largest problem, and I see that as a problem in terms of addressing this endoscopically, because I don't think any of the endoscopic approaches really will narrow that the hiatal opening, and so reflux for her is going to be a struggle. The first thing I mean, it's similar to POEM patients who have reflux after their procedures. I think one of the things that we don't do enough is counsel them on their dietary habit. And my guess is that, she's obviously gaining weight. And, for POEM patients, we find that they don't have much reflux if they just eat correctly in terms of like small meals, don't overeat, to the point that their stomach will reflux. And obviously she has a smaller stomach because of the sleeve, so she has less accommodation, and so she probably can eat less before she refluxes. But that would be the first place that I would just start. I would start with very aggressive medical therapy, dietary counseling. And then if that's not successful, and an intervention absolutely is necessary. Certainly discussing with the surgeons in a multidisciplinary conference on what her options are. And patients like this, I agree with you, Ken. I think her weight is kind of borderline low for an aggressive Roux-en-Y gastric bypass, but that's the definitive solution. There's no good wraps. Our surgeons at Stanford really don't like doing links. I'm scheduled to try and take a links out endoscopically because it's eroded through. So just their long-term experience now with links, they don't want to put them in anymore. With the sleeve, there's not much to do a fundoplication with. So I think it's a very challenging case. And I'd really spend a little bit more time with the patient to figure out what her short-term and long-term goals are. And really start with dietary modifications if possible, along with the PPI, see if we can address that. And if not, I think actually she's headed for surgery.
Thank you for that. Because we did an esophagogram and we thought there was a component of a paraesophageal hernia, so she was referred to surgery, like you recommended. So what further workup would this patient need? Do they need a pH study, do you think? Motility study, further workup prior to an intervention? She has tried for many years to modify her diet, lose weight, PPI therapy, and she's symptomatic, very symptomatic, and wishes for intervention.
I think the further workup would depend on what the surgeon is planning on doing. So if the surgeon's planning on doing a Roux-en-Y gastric bypass, I don't think much further. I don't think you need a motility study. I think you really need a motility study when you're planning to do a fundoplication, because there you're potentially adding some resistance. And if you have any issues with peristalsis, you're going to cause, further problems. And so that's typically why we would get a motility study prior to doing like a surgical fundoplication, not really a TIF, but a surgical fundoplication. A pH study, again, if they're planning on doing a Roux-en-Y, you're taking out the stomach anyway, so I don't think a pH study is going to matter. And she's highly symptomatic and has a large hiatal hernia. So I really can't think of further workups that I would do beyond what you've done. What about you, Ken?
Yeah, the new Chicago criteria is asking for LAB esophagitis as criteria for anti-reflux procedure or surgery. So she meets that criteria. So you don't need a formal pH study. You could, I mean, because again, the more data to confirm things before you do something that's going to be, nothing's going to be perfect, So certainly wouldn't be wrong to get a pH study. Yeah, I agree in terms of esophageal motility. If she has no dysphagia now, you certainly can do an endoflip at the time of your endoscopy or time of pH study. But unless there's, concern of a severe, dysmotility, and you're going to do some sort of fundoplication and or, tight hiatal closure, which can give you dysphagia, either one of those, then if she has dysphagia, then a motility study. But if without dysphagia, we're finding that the endoflip is more than sufficient to rule out achalasia, which is the main concern, obviously, for surgeons to do an anti-reflux procedure in someone who actually has achalasia.
You wouldn't be concerned about achalasia in this patient, though, with this image.
No.
I mean, it's
No,
so wide
no
open.
way, no way.
Yeah, right.
Yeah, exactly.
Yeah. So after the surgeon evaluated the patient, they wanted a pH study because consideration for possible links in this patient. So Ken, you've done endoscopic fundoplication for many years now. I have a two-part question. We talked about, the novel techniques with ARMS, ARM-A, all different wonderful new technology. but the endoscopic fundo, I think, has been around. So we wanted to ask you what has changed in your technique over the years. What is your current technique? And then are the other procedures you mentioned, is it prime time? Is it ready for consideration?
Yeah, so I've been doing TIF since 2008. It dates me a little bit, and over 500 cases. So I've learned slowly over many years to finally understand GERD anatomy and physiology. And what's really interesting, as I embarked on this journey, I assumed that the surgeons had figured out the anatomy and physiology and mechanism of GERD a long time ago, and hence Nissen and Toupet. But it turns out that's not the case. We're all kind of learning now the anatomy and physiology of GERD, and a lot of work, from our center, Nin's work, and so on, looking at how GERD actually happens. And so we're kind of rethinking and reinventing, the approach by really understanding the mechanism and trying to address whatever part of the mechanism is altered. So as I've learned the anatomy and physiology and continue to tweak the procedure itself to mimic the original design, that's been for me a great journey. And so now when I approach TIF, and Phoenix, you're a TIF expert as well, I look to get at least a 270, preferably a 300-degree partial fundoplication, sometimes 320 degrees. I try to get maximal length because there's no downside in more length. There is downside in tighter, right? And so with if I can get 3, sometimes 3.5 or 4 centimeter length, that would be ideal. I try to orient the wrap towards the lesser curve, because now we understand that the G flat valve swings from greater curve to lesser curve, and the lesser curve is more or less the backstop. We want to reinforce the gastric sling fibers instead of, with a surgical sleeve gastrectomy, you're actually cutting through the gastric sling fibers. So we're trying to reinforce the sling fibers, reestablish the angle of His, 300+ degree partial fundo oriented towards the lesser curve. That's the omega orientation, 3 to 4 centimeters in length. And we're also trying not to overdo it with too many fasteners and put fasteners on top of each other. But the fact that we can put 12 to 14 plications now, 24 to 28 individual fasteners, essentially, creating a very robust structure, which minimizes any twisting or kinking, which has a very long durability. I've had patients now out 10 years, and the valve looks, quite intact. So I know all of us here are doing TIF, and so I think as we grow, as we learn, we'll continue to modify it towards the optimal valve for each patient.
I've heard about the randomized control trial that was a multi-center comparing Nissen fundoplication and C-TIF, or concomitant hide hernia repair, and TIF. Do we have any results, and are there going to be studies comparing C-TIF and partial surgical fundo? Or
Yeah, there was a long debate before embarking. What would be the first, prospective randomized study that should be performed? Should it be C-TIF, which is combined hernia repair plus TIF, against the gold standard Nissen, or should it be C-TIF against where surgeons are gravitating towards now, which is a partial or Toupet? And after a lot of deliberation, it was felt that to go head to head against the gold standard, because that's what the payers, that's what everyone will want to know. How does it stack up against the gold standard, the current gold standard? So we've enrolled 120 patients thus far. We've almost hit our target, and we will have long-term follow-up within the next 6 months. So I think we're going to see great data soon. So more to come, but so far the study enrollment has almost been completed, multi-center, prospective, randomization. So I think this will be the landmark definitive study. And once we show at least non-inferiority between the two, then I think the next will be to compare it against partial fundo. But as I talked about in my lecture, the battlefront should not be, one technique versus the other. The battlefront shouldn't be Nissen versus Toupet versus Door, CTIF versus. I don't think that's where the battlefront should be. The battlefront should be, getting, the millions of patients who are suffering from refractory GERD to have individualized therapy, because right now the gap is humongous.
Yes. Well, thank you so much. That was a wonderful summary. I'm going to appropriately introduce Dr. Wang again. So Dr. Juha Wang is the Director of Gastrointestinal Endoscopic Surgery at Stanford, and we'll do a brief case just to start the discussion. Again, not meant to be an in-depth evaluation of this case.
I've seen this.
No, it's coming.
Yes.
The other one is coming. It won't look as pretty. I've seen the slides before.
Yeah, so we have a 60-year-old, again, a patient from our institution with a postoperative esophageal leak, history of a recurrent diaphragmatic hernia. And she underwent a redo, terribly complicated case as a redo, paraesophageal hernia repair with mesh. And a few days later, she presented with chest pain, back pain, and the on-call surgeon placed an esophageal stent for a esophageal leak perforation. Endoscopic team, or our advanced endoscopy team, was consulted a few days later for persistent drain output, and EGD shows now the stent in place, a large amount of pus inside. The stent was taken out, and it revealed a very large postoperative leak and a large cavity. So our question is, Dr. Wang, management at this point.
Yeah, it's a tough case, and this is where you would almost love to go back in time a little bit, because I think you have more, the sooner you realize what your options are, the better off you are. And it kind of goes towards, my discussion on endoscopic management of esophageal perforations. If you can identify an esophageal perforation acutely, which is really within the first maybe 48 hours, you could easily do a primary repair of that with the endoscopic suturing. And that, I think is by far the best potential outcome for a patient. And, like post dilation, or if you, if the surgeons recognize pretty quickly that they have, an anastomotic breakdown from doing a water soluble contrast esophagram, you can go in there and just suture without placing a stent, and that often will solve the problems. And our surgeons love to call us for things like that, because we can do more than they can, because we actually can see fresh tissue, healthy tissue, grab that, suture that, and really do a good job in essentially over sewing from the inside. So that's the best possible option. In this case, the leak was identified a little late, and then, it was done in the middle of the night, which it typically is. A stent is placed, which is very appropriate. That's the first thing, you see that. And if you don't have the ability to do suturing, you have to close that. Initially placing a stent is fine. But the problem with the stent can be this. I mean, it can make a small defect into a large defect, because there's a lot of pressure that goes on, and it can cause the defect to enlarge, and then the area can get infected, and then you're left with this large cavity. and this has to be drained. And so the chest is a tough place to drain percutaneously. So because sometimes I'm called by surgeons, well, can you suture this up? I said, well, if you don't have a drain and I can't suture this up, because then we're just going to have you're just going to have a closed abscess in there. So, if you're going to try and do an internal repair or stent it, you have to have an external drain, and you have to have it drained somewhere. So this one's probably so big, and the access percutaneously probably difficult. I think you have two options at this time. If it's like just truly contained and it's not free flowing, you can actually leave it alone. This one you can't because it's too big. So I think that actually the only option for this patient would be either take them back to the OR, and which is probably not a good idea right now, or do a vacuum sponge approach, where it's kind of one of the things that we hate the most. And it's the hardest on us, it's hardest on the patients, but it works, and it spares them a surgical procedure, and it's quite effective. So this is one where you would get a sponge. There's some kits out there. They're hard to come by though. So usually you're jerry rigging a small NG tube. You're placing one of those vacuum sponges that you can get out of a surgical sponge kit, vacuum kit, and advancing that endoscopically into this cavity. And the challenge with this is they have to, you'll have to do a oronasal exchange for this, or pass somehow, rig it so that you pass it through the nose. It's a lot of MacGyvering. It's very, very challenging, and the real challenging part is you're not just done with one placement. You have to go in there quite frequently and change out the sponge, check the area, debride the area.
How often do you change? Because it seems like in addition to arts and crafts aspect of it, the changing part is so
Yeah,
painful.
the timing of the changing part is really difficult. I would say no more than you really shouldn't go more than 1 week without changing it. And initially, we try and change it every couple of days just to see how things are going. And once we see, a improvement, we might extend out the interval, but I would say not more than every week. It's challenging though because of the logistics. If you're in a busy inpatient setting, these are time-consuming procedures. Sometimes you have to do them under fluoroscopic guidance to make sure you get the positioning correctly.
And do you try to put it into the cavity? Is that the main goal, or sometimes you're okay with leaving it interluminally?
Ideally, you put it into the cavity. At least something that's this large, you should get into the cavity.
Right.
If it's a smaller defect, so I've had defects that are kind of been in the duodenum, and the defect hasn't been that large. You can leave in the vicinity of it, and it just really helps to keep the lumen collapsed. I mean, the key is that you want to avoid distension. But I think in the chest, you really do need to get, at least for something this large, get it into the cavity. And it wouldn't be difficult. I mean, this
It's
looks like
big
it's
enough.
larger. I think it's harder to get into the esophagus than into this cavity.
Yeah, where is the lumen? Where is the lumen and where is the hole? Yes.
Yeah.
That's
But the
right.
thing is, after having done all the third space stuff and home, it doesn't scare you anymore, right? I mean, I think it's like, we're getting used to being outside of the lumen, and so this is becomes less intimidating. Let's put it that way.
But would you, just at the initial, would you say that the surgeon, when they discovered that at night, if they would have called the endoscopist right there and then, either to suture it or do it next morning, would have
The
been
next morning,
probably a better approach to that?
absolutely. I would have said if they would have just placed it, called us the next morning, we could have brought them down, and probably, could have,
Avoided some of it, yeah.
Well, thank you for that. Fortunately, our team wasn't covering that night, and for the next 2.5 months, because these cases, they are rare, but they come in through the ER, and the discussion, call the foregut surgeon or call the advanced endoscopy team. So this is what it looks like 2.5 months later of
That's great.
That looks
stenting, overlapping stents, and
How large
now
was
we
the
have-
original? So when I didn't get a good, I didn't see a good picture. How large was the original defect?
it wasn't that large, but
Okay,
again, this was the surgical, intervention. So
gotcha.
from our description or their description of it.
Okay.
So now we have 2 residual leak sites,
Mm-hmm.
and at this point, your management.
Well, those are, yeah, I mean, I think that those will eventually close. I mean, we have all kinds of, those are small holes. And so you can consider a variety of endoscopic closure methods to get those. I mean, it looks like those are like maybe 3 millimeter openings at most. So you could try something as simple as a clip. What I would do though is I would ablate that track. So I would be aggressive in terms of ablating the track and trying to expose submucosa. You want to get rid of the mucosal epithelium to allow the submucosa to basically adhere together and close. But you might be able to get away with just being somewhat aggressive in terms of ablating that track and then just closing it with either clips, or if you wanted to be aggressive, you can use one of the smaller OTSC clips. I wouldn't use anything too aggressive for a hole like that. What do you think, Ken?
Yeah, I agree. I mean, now the fistulas, these small fistulas, even though they're small, they're quite chronic, 2.5 months, and they've epithelialized. So you definitely have to, denude the mucosa. And as Juha said, ablate plus clip, ablate plus over the scope clip. I tend to even be more aggressive and if possible, ESD around the orifice, and then suture. So ESD plus suture, we do that for our GG fistulas. We ESD, so now you've got fresh, tissue, even around the orifice as well as in the tunnel, and then a box stitch suture. So that would be, another approach.
Yeah, I do it in an escalate. So, I would do kind of what I think is relatively straightforward and just see if that heals and give it one shot. And then if it doesn't, then I'd be much more aggressive in doing exactly what Ken mentioned and basically carving that area out, just really getting to fresh, bloody tissue, something that's really well vascularized, and then suture that area. But, initially when it's healed this well, from where it started, I would probably not be super aggressive on my first intervention. I see that you don't agree with me on any of my recommendations, but I'm 100% okay with this, and I might do this as well. It depends on the location and how easy it looked.
No, those are very wonderful ideas and suggestions, and there doesn't seem to be enough space or room, but the suturing device got down here to close the leak sites. And one more stent with suturing to hold the stent in place, and completion. This
Oh,
is what it
wow.
looks like.
Nice job.
Closed.
Nice.
Nice job.
So
one,
for
one
other-
comment, yeah, one comment I have on that. I probably wouldn't have put in another stent at that point, just because I don't want to put any additional strain on the sutures. So my tendency now, even if I go in and repair like a fresh perforation, I don't put a stent over it after that. If I feel like I got a good closure, I will just leave it. And then just do an esophagram, the next day, make sure that there's no leak and not put in a stent there, just because I don't want to add any additional strain to the or tension to the sutures.
Would you consider, if a cavity is very large with the suture included, would you consider adding endoscopic vacuum therapy on top of it intraluminally to have suctioning, or you would think the suturing is enough?
If it's a large cavity,
Yeah.
I mean, if it's a large cavity, then I think you have to start with
with
vacuum.
the,
And I wouldn't do any suturing. If I'm going to do vacuum, I'm not going to do suturing because
Okay.
it'll come together on its own.
Mm.
and then with vacuum, I wanted to ask you with cases like that, and that to both of you question, with cases like that, nutrition is so important. When you're doing vacuum therapy or even with stenting, how do you manage that? What would you do nutritionally for this patient?
Well, so with vacuum, it's not too bad. They already have one thing coming out of their nose, and so another thing's not going to bother them too much. And so I always try and feed them enterically. I mean, I really don't like TPN, and so I do my best to get enteric feeding in, and so that would be the general goal. I will have to say just one comment, kind of, it's really good to have a dialogue with your physicians or your surgeons so that
Right.
you know what they can do. The last time I had to do a vacuum, place a sponge to do vacuum therapy was probably 3 years ago. And so, we really have communicated well with our surgeons. And, if there's a patient, and the time that we had to do it is because the patient was sitting at an outside hospital for so long before coming in. And so, it really is, communicating with your surgeons on what you can do, what they can do, and working together and trying to get the best possible outcome for our patients. And I think just endoscopic suturing, I love. I think that alone has reduced so many hospital stays, has improved surgical, our management of post-surgical complications have just, I think, been revolutionized and really have made us great partners with surgeons.
For
Dr. Chen?
other chronic fistulas, Juha, can you briefly talk about the use of fibrin glue, other injectable substances?
Yeah, for the most part, I don't think they work. I mean, if they're chronic fistulas, I just did a case yesterday. It was a chronic peg tube track, right? And this thing was just hard and fibrotic. There's nothing, you can inject anything in there and nothing's going to work. And it's because it's fibrotic, right? I mean, it's the same thing as that esophageal fistula tract. If anything, you have to be even more aggressive and just carve that tissue out, carve the scar tissue out, and then sew that back together. So, maybe for really tiny, long fistulas, I would still go in there, and you can't really do much, or you want to add something, you could consider, ablating and then maybe inserting some fibrin glue. But, for the most part, I found that any injectable agent really doesn't do much except for add cost. Any thoughts, Ken?
Totally agree. With wound closure, we don't think about these three steps as endoscopists, but as surgeons, they think about approximation and then fixation and then sealing. These three need to be thought about separately. The sealants and the glues, that's like icing on the cake. So if you've approximated and you fixated and the edges are very close, but you just want to seal it, then these things may be effective. But if you've got
Pixie dust.
exactly, a little bit of pixie dust at the end, a little the icing on the cake, that's how I do them, but not as a
Primary modality of any kind, yes. So, Dr. Chen, did you also move away from the sort of stance towards suturing and approximation and fixation that way in your practice?
Yes, very much so. We just had a very complicated, interesting case. I did a C poem, Juha. I did a C poem, cracopharyngeus myotomy without his anchors, and a fellow misplaced a clip, and the next day there was a leak, and we jumped at it right away. We took out the other clips, we reclipped it, but then even despite that, the tunnel, the mediastinal tunnel got larger and larger. And now we're in the hypopharynx. Stenting is not great, suturing is not great. And this mediastinal tunnel was getting larger in front of our eyes. So, we reviewed a paper in Video GIE by Norio, who had a similar case. I called Norio up and So we actually went into the tunnel and we put in a EOS needle from the tunnel into the esophagus, VisiGuide wire, then a nasocystic tube retrograde from the esophagus back up into the tunnel, and attach that to a suction bulb. So now you have gravity dependent drainage. And then, but the incision got larger and larger. So then we used sutures to try to approximate this now 5 centimeter incision that's wide open.
Wow.
We had to use pledgets on the needle anchor side so it didn't rip in the hypopharynx. We got the approximation down to 0.5 centimeter, and then put in a 14 millimeter, 6 centimeters long covered stent, and prayed hard. And after a week, everything sealed off.
Incredible.
That's a lot of praying, you
That's
know.
a lot of praying. So yeah, I mean, all the surgical principles had to be applied. Yeah.
Wow.
Well, that is an amazing case.
Yes, we appreciate you both very much for coming on today and to fully discuss the cases. And we look forward to seeing you both very soon, hopefully in person. Sonia, would you like to say a thank you and close?
I would, as always, and we hope, as Phoenix said, we have a lot of exciting things planned for end of June, and hopefully things work out and we'll see you in person.
All
Thank
right.
you everyone
Thank you.
for attending this session. Bye-bye.
Bye-bye.
Bye-bye. Thank
Thank
you.
you.
Bye-bye.